Public dialogue and civic engagement are important. They play a role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is proud to support Texas Tribune events like the conversation you're about to see.
Please join me in welcoming our distinguished panelists. Thank you for being here. Thank you all, and thank you, panelists. Let me begin by creating a frame for this conversation. The cost of health care in Texas is undeniably hockey sticking. For years and years, if you know anything about the state budget, education was far and away the #1 line item in the all-funds budget, no close second. And in the last several biennia, health care began to creep up as a percentage of the budget for a whole bunch of reasons that we'll talk about. In the biennium that began on September 1st, health care is now, depending upon who you talk to, either equal to or slightly ahead of education for the first time ever as the #1 line item in the all-funds budget. We know that part of that is a conversation about access to insurance and access to care. Texas has the most citizens and the highest percentage of its citizens without health insurance of any state in the country. But that is not the only conversation point that leads us to the healthcare cost situation we're in. Dr. Varga, you work with and alongside a lot of people who run institutions that provide care, hospitals, healthcare facilities. From your end of this conversation, from your perspective, why are healthcare costs going up so much?
Well, I think there's two major aspects of that. One is an issue of access and one is an issue of utilization.
Access and utilization.
Yep. So from an access standpoint, you've heard this mantra probably many, many times that the objective of a really efficient health system would be what the Institute of Medicine has called STEEP, safe, timely, effective, efficient, equitable, and patient-centered. That also implies that in that model you should be delivering the right care, the right place, the right time, with the right healthcare professional. And so access, meaning that if you don't have a primary care medical home, if you don't have access to basic care, you tend to access the healthcare system in the wrong place at the wrong time with the wrong set of professionals. You come to the ED when you're really, really sick, you end up in the ICU, and you end up with a lot of specialty-related costs. It's absolutely appropriate care. It's just it was wrong care at the wrong time in the wrong place. The other issue is utilization. So put that whole issue aside and just look at an incident of care, an episode of care. In North Texas, if you look at severity-adjusted cost per discharge in our marketplace, the cost per adjusted discharge can range anywhere from 30 to 50 to 60% more expensive for the same episode of care as the national average in the United States. And what that, if you go back and say, let's look at the health system and say, well, is it the labor cost? Is it the drug cost? Is it the supply cost? What's the rationale? You look at most of the health systems in North Texas, probably all are at the average or maybe even a little below average from the standpoint of what it costs to have nurses at the bedside, what it costs to acquire and utilize drugs, buy implants for total joint replacements, et cetera. The overwhelming reason that our cost per adjusted discharge is different is we utilize more care for a given episode. We keep patients in the hospital longer, we do more stuff to them and for them while they're in the hospital, et cetera. Those two are inextricably interwoven. The right access model and then the utilization model.
Is that a good thing, Dr. Varga? Why can't you control that? Since you're the ones who keep them there and you're the ones who treat them, why can't you do it in less time and without doing as much stuff?
So right now there's two aspects of that. One is kind of a community standard of care, what's expected. Right. So that's one issue. But the other issue is the issue of physician-driven utilization. I mean, at the end of the day, it's a big piece of it. And
so so it's really on the doctor, it's not on the institution.
Correct.
Right. Well, we happen to have a doctor right here, conveniently. Are you the problem, Dr. Bornstein? I did separate the two of you. I didn't realize there was a good reason to do that.
Well, first of all, we're both interns.
I get it. All right, yeah.
You're just like
today. You're wearing your hospital hat.
You're just like my medical staff, which is I don't get credit for my MD.
Right. Well, are doctors the problem? Are you the reason that costs of healthcare are so high because you do too much stuff and take too long to do it?
Oh, I think I don't think that there's anyone in this that can't do a better job, whether it's physicians, whether it's institutions, whether it's health plans. So I don't think to single out any particular individual or class of individuals is that helpful. But yes, I mean, the old adage is the most expensive thing that doctors have is our pen, right? And that is true. And so how effective this will be in the long run, I don't think we really know. But we do have things, for example, you may have heard of the Choosing Wisely campaign. You may have heard of that. It's an effort from the American Board of Internal Medicine. Now it has about 70 other organizations really looking at diagnostic testing. And, you know, the provost was talking about safety. So we talk about safety, but we also talk about cost. I think they're related. But for example, and this comes up all the time, physicians should not prescribe an antibiotic for an uncomplicated upper respiratory tract infection. Seems simple, right? But if you're in the exam room with that patient and the patient is saying, well, my other doctor always gave me a Z-Pack or a whatever pack, then you have to have the conversation in your 15-minute visit with that, or 10-minute or 12-minute visit. So yes, so I think education of physicians, what are the things that we do to patients, for patients, that are effective and that are helpful and that are not harmful? And that's the other thing. We take our vow, first do no harm. So it's not just a matter of cost, it's actually avoiding harm too. So yes, physicians can be educated and should be educated.
And do have a role in this conversation.
Absolutely.
So to the two elected officials here, you know, obviously people say, well, the cost of health care goes up, and the solution to that must come from the medical professions. But the reality is you all have your hands, Representative Collier, on a lot of this yourselves in Austin. And the dollars that we spend on health care in the state budget are dollars we're not spending on other things. We're not spending them on transportation. We're not spending them on education. This is a choice, not a referendum, right? So are you satisfied with the way that we budget for health care, and what can you do about it?
Me personally, I'm not satisfied with the way that we budget for health care. We've underfunded women's health programs. In fact, we cut the Medicaid women's health program not too long ago, and so we have more women who have lost access to health care. But going back to what the doctors were saying about the power in the pen, you know, we as lay people, we're not educated enough to know what to ask the doctor to prescribe or what to do. So when I go into the doctor, I'm relying on that doctor to give me the best, you know, medical service that they can. So I don't know not to say, well, can you give me the lower price antibiotic, or is there something else I can do instead of that? Because if it's coming from your mouth, I'm taking it as true, because that's what you've taken the oath to do, to provide the service. But I think one of the problems is that if they're in the emergency room, Dr. Varga, you talked about how people go to the wrong place to get medical treatment. If they're in the emergency room, the cost is going to be higher as opposed to if they went to their PCP. So if they're going in there for an upper respiratory infection in the emergency room, it's going to be 1 to 2 times higher than it would have been in that physician's office. Right. And so if that emergency room doctor has that one chance to see that patient, perhaps they will do more than they would have if they were in the PCP setting, because then they would likely see that person come back. But in the emergency room, they see that one person one time. This may be the only shot that they have to try to address their condition. And so they probably do go above and beyond to cover it. Right. But in the end, it ends up being uncompensated care.
Right, so both you and Dr. Varga have mentioned the emergency department, and I actually thought you were both going to run immediately toward the idea that people without health insurance often show up in the emergency room and are treated, and that is the most expensive and least efficient form of care. Those costs passed along to all of us in the form of property tax increases. You and the legislature can't cause Dr. Bornstein to treat a patient differently. You can't cause the hospitals that Dr. Varga works with to treat patients differently. But you can make a decision, directly or indirectly, about who gets access to health care and who doesn't, or who gets insurance and who doesn't. And the legislature has had something to say about that. What they've had to say about that is no thank you to the federal government. Representative Collier.
Well, and that's unfortunate, because we are turning away millions of federal dollars that could help Texans. We're 19% uninsured in Texas. We're one of the highest uninsured, and we've got 27 million people in our state. And it doesn't have to be that way. If we were to fully implement the Affordable Care Act, we could reach more people. In fact, there's over 700,000 people in Texas who fall into the coverage gap. They don't have access to health care. And there's estimates that say over 400,000 of those 700,000 would qualify for health care coverage within that gap. And that's closing the gap on health insurance. And that's helping people to find a medical home, helping them to have access to that care where they can get medical treatment on a regular basis and not, you know, have these exorbitant bills. And this would take some pressure off of our county hospitals, our private charities could do more in the communities if they didn't have that burden on them. So we do have a lot of uncompensated care, and you know what? By turning away the federal dollars, we're only hurting Texans.
And ultimately, the cost curve is not being bent in the right direction by that decision, you would say, Representative
That's
Collier.
correct.
Representative Klick, I know you to be a compassionate person, but I also know that you have the completely opposite view of this issue from Representative Collier. Would you explain why you think whatever else the legislature should be doing, that is not what it should be doing?
I believe that at the federal level and at the state level that we are on an unsustainable trajectory, and we've got to do some reforms. You know, I saw a report yesterday at the federal level. Federal health care spending exceeded Social Security for the first time.
Right.
This
They're having the same problem we're having. It's
Right.
going up and up and up.
It's not sustainable.
Right.
We need to look at other models of providing care. And I very much agree a medical home is very important, because if someone has access to primary care, then they're not, you know, utilizing the emergency department
Right.
all the time. And that is a cost savings. But there are many things that we could do that could drive down the cost of care. What we need right now is some disruptive innovation in healthcare.
Well, let me ask you to be specific. I don't mean to put you on the spot, by which I mean I do mean to put you on the spot. Because, you know, it is often said about this legislature, and I've certainly said it myself, they're very good at telling you what they don't like. They're not so good at telling you what they do like. So we get the fact that we don't like the Affordable Care Act. Elections have consequences. We've elected a conservative state government. Peace. So now tell me, if we're not going to do that, what are we going to do? You said there are some things we can do. Tell me what some of those are.
There are a variety of things that we can do as far as setting up some other product other than just Medicaid.
Yeah.
Medicaid has very poor outcomes when you compare to other payer systems.
Yeah.
You know, one of the things some of the other states are piloting right now, and I would like to see Texas pilot, is direct primary care to a Medicaid population.
Explain how that would work to the people in the room.
What that works like is you have got a physician or a physician group that they're being paid monthly or annually to manage the primary care of an individual. That, coupled with a health savings account and a catastrophic plan, the studies that have been done in other states so far, it has had better outcomes and lower cost. And it was certainly less costly than a bronze plan under the Affordable Care Act. And I think we need to be looking for those.
Yeah.
A lot of these direct primary care providers, they have chosen not to accept insurance. And the reason why is because of the cost of that overhead.
Right.
And they are finding that they can see more patients
Right.
and spend, you know, less dollars on that, and they're enjoying their practice more.
Now, Dr. Bornstein, what one will hear, what I will hear from docs is, you know, the fact is that the Medicaid reimbursement rates are atrocious. I think they're at the lowest level in Texas than they've ever been. Is it 34%? I think 34% of doctors now are taking new Medicaid patients, which is the lowest number. The legislature had a conversation during this last session about whether the Medicaid reimbursement rate should be what it has been, which is, I think, about 64 cents on the dollar.
Yes.
There was some discussion of possibly taking it back up to 100%. Now, but the legislature voted ultimately in the budget that passed to keep it at a much lower rate. What Representative Klick is saying is absolutely true, that there is an economic motivation not to see people under this system.
Sure, absolutely.
As a doctor, do you advise your colleagues to take Medicaid patients? Do you think there's an important role for you all to play in doing this, even though the economics of it might not work out to your advantage?
Absolutely, absolutely. And I think that if you look at the numbers, it is true that the number of providers that are seeing Medicaid patients, new Medicaid patients, is decreasing. But let me point out something about the Medicaid in this state, and that is, as an internist, Dr. Varga or me, for an adult person in this state to be covered by Medicaid, they are usually aged, blind, disabled. They have some kind of severe comorbidity. So Medicaid in this state, by our legislature's design, is a very narrow coverage situation. And so, if you're a pregnant woman or if you're a young child, as I said, some aged, blind, disabled folks. But if you're a a working poor person in this state and you're an adult, man in particular, you're not going to get covered. So I think the conversation, to me, has to be more broad than just let's give Medicaid more money.
It's not only a Medicaid issue.
That's right.
From your perspective. Dr. Varga, from the institutional perspective, how important is the Medicaid piece of this conversation?
I think it's very important because it's a really incredibly important piece of the safety net. But I would actually say if it doesn't necessarily have to be a crippling economic model. If you look, for example, at the dual eligible population that's in Medicaid, so they have both Medicaid and Medicare, and it's that group that Susan was just describing, age, blind, disabled, et cetera. Some of the most complex people that you will ever encounter in terms of the care needs that they have. But if you look at what the typical physician practice model is built to address, it's not anything that they need. Because groups, for example, in California where they have really comprehensive managed Medicaid out there, so it's managed care Medicaid, the health systems that accept those patients basically put almost all the dollars into three things: primary care access model, behavioral health, and end-of-life care. Yeah. Now, those are three things that I would suggest a three-person primary care practice does not have access to. So you're talking about, to be successful in the economics of Medicaid, you actually have to have a more socially oriented model that actually deals with the real social issues that the individuals have, as opposed to say, I'm going to treat them just like a Blue Cross Blue Shield patient who's walking in with a $10 copay and a $1,500 deductible, who had a way to get there in a car, who when they get home know where their pharmacy is and have a pharmacy that will accept their insurance. And oh, by the way, they also have to get to see their counselor. They also have to get to whatever it happens to be.
So there's a limit to how much you can do, right?
Yeah, absolutely.
There are more services that you have to provide to a more in-need population.
If you're talking about what is the common access model in Texas, which is the small independent primary care physician.
Yeah. Representative Collier, what Representative Klick, I'm going to put words in her mouth, but I've heard her say them, so I'm confident in doing so. What Representative Klick and people who are politically aligned with Representative Klick on this issue would say is Medicaid is broken. And the federal government can't lead its way out of a paper bag with a flashlight and a map, right? So why do we want to tether ourselves to a broken system administered by a broken federal government? Why don't we want to take responsibility, as we like to do in Texas, for ourselves and create some Texas model for solving this problem?
We don't have the resources or the ability to do that. We cannot do that on our own. The price of oil is going down. That means our rainy day fund is going to go down. We're going to have less money to be able to handle the health care needs of Texans. We have more Texans coming in to each state. Not too long ago when we defunded the women's health program in Texas, Texas had the great idea to create their own network for women's health. And they felt like they were going to be able to fill the gap and fill that need for women's health. But in fact, over 9% of the care has been, we've lost 9% of care for women in Texas because we defunded that program. And it was really politically motivated to get rid of Planned Parenthood, who was meeting the needs of Texans to provide the care that they needed for women and for men and for young adults.
So you believe, Representative Collier, in a state that has finite resources, we simply can't take on the responsibility of solving the problem?
We cannot do it all on our own. No, we cannot.
Right.
If you say that the issue is not, the federal government is not the answer, we'll do our own, we do not have the resources to take on this large need, this requirement, obligation on our own. The direct care that you talk about, that sounds good and dandy, but how is that going to affect the administrative costs for our physicians? Because if you say you can get direct care, but then it wouldn't be 64 cents on the dollar, it would be 30 cents on the dollar, and then you would have less than 30% of the physicians accepting that particular type of care. And so I think that there's got to be some balance in there, and you got to look at it. The Federal Affordable Care Act is available right now. We're turning away dollars. It was 90% in the beginning, and we're just letting that money go to waste when we could have been implementing it and refining it all along. And so we had that opportunity, but we're just letting it go day by day.
Representative Klick, let me you talk about disruption as potentially one answer here. Let me go all the way to the end of the disruption spectrum. I was with your former colleague, maybe you didn't overlap in the legislature, but he was a former member in any case, Alan Ritter from Nederland, a couple of sessions ago in Beaumont. And I asked him about a version of this conversation, and he said, where does it say in the Constitution that people have a right to get health care? Why is the government even in this business? You want disruption? Here's some disruption. Get out of the business entirely of providing access to health care. Do you think we need to go that far?
I think that Medicaid and some other programs are important safety net programs that the public...
You don't want to relitigate the social safety net completely.
Not entirely, but I think that we can do a better job. You know, we talked earlier about a hospital that was in a community that was primarily senior citizens.
Right.
There's not a one-size-fits-all solution.
Right.
You know, different communities have different needs, and that we need to craft solutions to meet the needs of those communities.
Yeah.
It's best done at the local level,
Right.
not in Washington.
Would you grant, just as you don't diagnose every single patient's illnesses and create a course of treatment for every patient the same, why should the system provide essentially a one-size-fits-all, Dr. Bornstein?
I agree, and I think I have to speak with pride of my county medical society right down I-30, a little bit east of here, about 30 miles. The Dallas County Medical Society. I think other medical societies have done similar things. We really tried to meet this challenge with our Project Access, which was, by all accounts, a wonderful success, where we paired physicians with patients in need and had some of the hospitals and diagnostic facilities on board. And it was a very, very successful project. And then it wasn't. So the 1115 waivers came along. And so that's can be rehashed a number of times. But I would agree. I do think, and especially, I think we're all aware the size, the magnitude, the diversity, the complexity of this state in particular. I mean, this is not Rhode Island, right? This is a very diverse, complex state. And so I would agree. I don't think one size fits all, and I think that there needs to be local involvement in this disruption.
And so if you tailor healthcare for each individual community, possibly those communities may themselves be able to keep the costs down based on customization. I want to come back to diversity and demographic inevitability, which I think overlays every conversation that we have these days about public policy in Texas. But I want to ask Dr. Varga, ex-Kentuckian, about the experience of his former state. So Kentucky is not maybe as red a state as Texas. What could be redder than Texas, right? But politically, Kentucky is a pretty red state, okay? And yet, for the last several years, Kentucky actually lived under Medicaid expansion.
That's right.
Right? Now, we have a new governor, Matt Bevin, who was elected to replace the old governor, a Republican replacing a Democrat, not just any Republican, but a grassroots conservative who replaced the Democrat, and is essentially dismantling in part or in whole the system under which Kentucky operated from a health care standpoint, as he promised. Can you talk about the experience of Kentucky as a red state living under Medicaid expansion? From your perspective, how politically did that work? And did it help get on some of the issues that we're talking about today?
Well, I didn't live, I've been here for 3 years, so.
But you know Kentucky better than any of we do, of course. Right.
Fairly well. First of all, to put this in perspective, there are more uninsured patients in Texas than there are people in
residents of Kentucky.
There are residents of
Everything
Kentucky.
is indeed bigger here,
Right.
stipulated.
Very close, though, at a percentage basis to the same sort of reality Texas faces, but with one big difference. Kentucky is a very poor state, carries an enormous disease burden, the highest cardiac death rate in the country, highest smoking rate, highest obesity rate, not a terribly well-educated state, not a growing state. If you look at also the reality of the payer mix of Kentucky, it's only about a third commercial insurance. The rest of it is Medicare, Medicaid, and self-pay. So the other piece of that is it has two huge safety net entities, the University of Louisville and the University of Kentucky, who kind of underpin a lot of the safety net care that occurs, particularly on the specialty level. The expansion of Medicaid in Kentucky, actually, if you step back and look at hospital performance economically over the last couple of years, hospitals that were losing money or barely eking a margin all of a sudden started breaking even or started making fairly large margins, particularly the university hospitals who have a unique arrangement where all Medicaid patients have to be paid at commercial insurance rates in Kentucky. Wow. So University of Kentucky, University of Louisville hospitals did very, very well. A lot of hospitals did a lot better. There's no question that the access model expanded. I don't know that Medicaid expansion was necessarily designed to help not-for-profit hospital bottom lines, but that was actually a reality of it. But one of the reasons Medicaid worked so well in Kentucky, and I think this is an indisputable fact and circles back to the comment I made at the outset, to survive in Kentucky, to survive as a hospital in Kentucky, you have got to have a cost structure that's so low that you can survive on Medicare alone.
Wow.
If all you had was Medicare, you could break even and continue your not-for-profit mission. So when all of a sudden a bunch of self-pay patients actually had some insurance, forget what the rate was, some insurance, the cost structure is in the state is such that, you know, off you go. You actually are now now profitable or making enough to reinvest in the capital requirements you have. That's one of the dilemmas around Medicaid expansion that Texas would face right now, is throwing some Medicaid dollars at a very expensive cost structure doesn't really dent Texas's burden that they carry.
One of the many ways in which we're not Kentucky. So what will the impact of dismantling the system under which Kentucky lived previously be, do you think?
So what they're doing is largely disconnecting their state exchange. So the assumption would be that most of those folks will then navigate their way into the national exchange. Their subsidies continue, et cetera, but Kentucky Connect, which was the vehicle that was used, has been declared, I think, universally as the most effective routing mechanism in the country for getting patients who qualified for subsidy into the insurance program.
Right. Representative Collier, Dr. Varga mentioned diversity, or Dr. Bornstein mentioned the diversity. We are in an incredibly diverse state now. It is getting more and more so. It is also, unlike Kentucky, fast growing. 20 million of us in 2000, 27 million of us today. By 2050, the population of the state will double. In that time, the Anglo population will drop precipitously, the Latino population will increase, the African American population will slightly increase. The population of seniors between now and then will double in the state of Texas. What does this tell you about the future of our conversations around healthcare costs, the changing nature of the population? Growth of the state, increasingly diverse, older. What does that tell you?
Our costs are going to go up. It's no question about it. Our costs in our state are going to go up. Right now, about 30% of those 19% that are uninsured are Latino or Hispanic. 16% are African American. These are high numbers in our population, and if the Latino or Hispanic population is going to double, then those numbers are going to grow. We're going to see the uncompensated care, we're going to see the cost of health care, the contributions from the state increase, and that means some other parts of our budget are going to decrease because we're going to have to make up for that care. So we've got to find ways, and I do agree with Representative Klick that it's not one that can be just for every area, because every community, if you live near a border town, if you live here in the city, if you live in the rural areas, you have different needs, and we do need to find a way to craft health care for you. You mentioned the 1115 waivers, Dr. Bornstein. Yes, the whole goal was to create health care for your community through the 1115 waiver. Right. But we just didn't have time. The time was so limited on how you can, because what we charge the communities to do, the counties to do, is you need to create a program that's going to address the needs of the community for those who don't have health insurance. What is the program that you're going to create? And we're only going to give you maybe not even a year to get it done. And so, that was one of the problems. But the purpose of the 1115 waiver was to try to fill the gap of the missing money that we didn't have. Texas was going to draw down some dollars for our counties and those communities to try to find programs that would be specific for their areas, that would address their needs. We just haven't had time, and so we're still trying to scramble and find those programs. It's just a lot of work when they're actually trying to provide care, when they're trying to make money, try to stay afloat. So it's pretty difficult.
Dr. Bornstein, you work in an area of the state that is diverse. You see a diverse patient base. You have diverse friends and neighbors around this community. What does the increasing diversity and, by the way, the fast growth of the state mean to you in terms of how the healthcare cost picture will change? I
completely agree with Representative Collier. If we're in trouble now, we're going to really be in trouble in 10, 15, 20 years. And one of the things that I meant to say in the original comments, the early comments, was think about this. Think about one of the reasons I think that people don't talk about a lot, why we are in the situation we are in, not just in Texas but nationally, is the whole idea of chronic disease, right? If you think about this, 20, 30, 50, 60 years ago, people didn't have chronic diseases. They got something and they either got better or they died, right? So you look at heart disease. People died from heart disease prematurely. Well, now they don't necessarily. Diabetes. This is, people worked on farms. They did manual labor, and they didn't eat fast food all the time. And so the whole notion, the whole proliferation of chronic diseases is something that I have to say I think it has sort of taken people by surprise. And so now here we are. There's no evidence that that is going to diminish. I don't think so.
So you'd like, Dr. Bornstein, for there to be a public campaign against certain behavioral decisions that people make in order to try to get their health under control?
I think we have to look at the social determinants of health.
Right.
And I'll never forget, I'll take very brief to tell you a story about the health commissioner for Louisiana after Hurricane Katrina, who happens to be an intern, is Karen DeSalvo. You probably know. She told a story, a riveting story about she was still on the Tulane faculty, and they were right a few days after the hurricane. They were trying to set up little mobile camps and tents to give medical care to people that needed them. And so somebody's a diabetic, and they say, well, how's your blood sugar? I don't have a house. I don't have a bed. I don't have any place to sleep, so don't ask me about my blood sugar, okay? So I think we don't do a great job in this state of looking at the social determinants, whether housing, education, safety net type thing. So I think they're intertwined.
I'm concerned. I'm looking at Representative Stephanie Liberty Klick, wondering how you would feel about a mandate that the government somehow get into business of telling people don't smoke, don't eat fast food, don't do this, don't do that. I mean, our agriculture commissioner just put fryers back in schools. We seem to be going in the other direction. But is there a role to play from the state level, whether it's agency or government, saying to people, look, the way to get out ahead of healthcare costs is stop doing these things?
I think certainly there is a role in some education programs. Yeah. But at the end of the day, we have to make a compelling case for people to change their behavior.
Right. Is there a way to keep, I mentioned liberty because it's Texas, right? Is there a way to keep the politics out of this conversation? I remember talking to State Senator Seliger when he was chair of the redistricting committee, and I said, can't we make this less political? And he said, taking the politics out of redistricting is like taking the calories out of fried chicken. I wonder if there isn't a version of that for health care. Taking the politics out of health care these days is absolutely impossible. But this is a political issue as much as it is anything, is it not?
It is a political issue, but I think that what it boils down to in many, many cases is who is best to solve the problem. Right. Is it better that government solve it, or are there free market solutions out there? And we have free market solutions that are reducing the cost of care. Yeah. And we need to get out of the way and let those flourish.
Right. Dr. Varga, at the beginning, I did hear this, and I've repeated it a couple times because I think there's an undeniable truth to this. Disruption is solving all the problems of the world these days, or at least we think it is. Mm-hmm. Representative Klick mentioned the possibility of disruption. Well, often disruption means technology, at least in the world that we live right now. Mm-hmm. There are a number of technological advances in medicine, in the treatment of patients, in the administration of care, that are in discussion these days. Now, they're not without controversy. I mean, I was going to say, well, there's no politics in technology, but look at the fight over telemedicine in the last legislative session. There are a lot of rural communities that don't have access to docs and don't have access to practitioners, and so people say, well, let's put telemedicine in. Well, you think that's not a political football? It most definitely is a political football. How is technology going to be part of this conversation, and how do you depoliticize the disruption, if you can, that Representative Klick is talking about?
Well, I mean, there's going to be technological disruption at two levels. One is the standard thing that we've seen through the years, which are the advances in medical technology that allow you to do more and more and more. And one of the things we've never really done in healthcare is actually ask, as you bring on board new technologies, for whom and in what situation should you actually use those technologies? It's not rationing. Right. It's called appropriate care. It's, does every single surgical procedure we do in the world need to be done through a robot? The answer is no. It increases the cost of care per case significantly, but there are some cases that the data is overwhelming that the robot is absolutely the right way to do the care. So that's one end of it. The other end is one that we've never seen, never dealt with, and telemedicine is tip of the iceberg, and that is when consumers get a hold of wearables and technology that sends data from wearables, implantables, whatever else you want to talk about, trying to figure out how to deal with that data in a system that's already challenged from an access standpoint is going to be crazy. Now, that said, flipping back to telemedicine, I would tell you that I think it's a huge, huge dilemma in our state because we have a huge place with a very compromised access model. And I can tell you in my little state, back in Kentucky, where 2/3 of the counties were federally designated underserved, where you had counties of, 25, 30, 40,000 with 0 doctors in the entire county. We actually were able to put in place a model of primary care that used a multidisciplinary, non-physician team connected to physicians 50 miles away in Lexington, not to say, let's see you if you have a stroke, let's see you if you need a specialist. It's how do we deliver primary care in Campton, Kentucky, population 10,000, 0 doctors in town. And within 3 years, 7,000 active patients in that practice. No doctor darkened the door of Campton, Kentucky, but they had unlimited, universal access to doctors through telehealth.
Was there a scope of practice fight in Kentucky the way there is in Texas?
Yeah, I mean, there was, but I think what people got to...
I'm hitting all the buttons.
No,
I'm trying not to look at Steve Levine.
There is a scope of practice issue without question, but I think as opposed to speaking about scope of practice in a very expensive system that has limited resources, we've got to start talking about top of competency instead of scope of practice, because you look at it, doctors, nurses, APRNs, the way that we utilize those skills today, most of those people spend most of their time far below the top of their competency.
Yeah.
In large part because either A, they have to because there's no other resource, or B, the way they get paid is to live way below their top of competency.
Let me stay within this question of whether we have an adequate number of providers, whether it's electronically or in real time, in person, not virtual, but in person. Dr. Bornstein, it's often said that if all of a sudden Representative Collier's side of this argument on Medicaid was successful, we expand Medicaid and everybody in the state who does not have health insurance today now has it, we actually have a capacity problem. If you suddenly tomorrow had everybody in the state with health insurance, do we have enough doctors? Do we have enough facilities? Do we have enough of everything? We actually don't,
No.
right? We have a capacity problem.
Right, we definitely do. And I think people have found that out that are newly covered under the Affordable Care Act, that insurance does not equal access. And so I will thank our legislators this last biennium for increasing funding for graduate medical education. Thank you very much. Right. That was huge.
We have a couple of additional medical schools coming online in Texas, which hopefully means that we create more docs, right?
Well, yes.
Yes,
we don't have
we don't have no
imbalance.
Yes,
Hopefully.
but,
I underscore, hopefully.
Yeah.
I'm trying to be positive because Dr. Varga was bumming me out there for a little while.
I do want to say something about telemedicine, and I think it is one of the real hot button issues. And I think there's, as he described it very nicely, I think there's tremendous use, appropriate use for it. I do think where it's problematic is accountability. Okay, so you described a system in which the providers are accountable to each other and to the patient. And I think where the breakdown comes from my mind is in a for-profit or maybe not-for-profit, whatever entity that you can go online and you can put in your information and you talk to a provider that doesn't know anything about you, will never see you again. There's no accountability. And I have to tell you, I think the best kind of care that anybody can get is relationship-based.
And that maybe the cost of health care, whatever else it is not, it is tied at least in part to whether doctors feel that they're and providers feel that they're accountable.
Right. Right.
We're going to go to questions here in a second. Let me let the last words go to our state representatives. Representative Collier, so you're now in the interim between the 84th and the 85th sessions. You've got charges from the House side. You're going to be studying a bunch of issues. I hope it is fair to say that all the other issues of the state notwithstanding, health care was an issue that did not get very much of your attention in the last session. You didn't really do much on this question, Representative Klick, on health care costs?
Actually, I would disagree with you.
What did you do that I missed? Because I kind of was paying attention.
There was one bill that I worked with Senator Burton and Dr. Sheffield. It is a pill donation bill where pharmaceutical products that are unopened can be donated and reused. You know, a lot of pharmaceutical products now are terribly expensive. We're moving more to oral chemotherapy. The cost of those drugs can easily be, $20,000, $30,000 a month.
Well,
and if therapy changes,
accepted, but that's kind of a piece of the puzzle. You all didn't tackle the puzzle.
We also did more in regards to moving different populations that are on Medicaid into managed care. And that
So you feel that's going to have a significant result?
It is,
Right.
because we've been able to take people off the interest list and provide services that have been waiting for years.
Representative Collier, did I miss it? I mean, maybe Representative Klick is right. Maybe I just missed it. It felt to me
Well-
like healthcare was a big whiff for the last legislature.
Well, we didn't do enough. I mean, the managed care program is already broken, so why even move them over into that managed care program? We need to look at that. We need to do another look into that whole system of the managed care, providing managed care.
Right.
But what we did was we created a study. We created a study to look at the healthcare and what we're doing in Texas. That's all we really did. We didn't actually throw money into it. There may be some glimpses of opportunities where we can save small amounts, but it didn't really do much as in terms of a fix or
So will you, so I guess my question is, will you next time? So the
We have
85th
to.
session is right over the rise. I suspect if I could tell you today who is going to be president when you gavelled in or not long after, that might tell you something about what your disposition on this topic was, right? Let's accept that. But do you think that the 85th session will be different in terms of its attention to this question than the 84th was?
It depends on who's elected.
So it does matter about that. Representative?
I believe that it does. I believe that the Affordable Care Act is already crumbling under its own weight.
So
It's
President
not
Trump will fix
sustainable.
this? Or President Sanders will fix this? Is that right?
Whether they directly do it or not, I think the fiscal reality is that it is going to be to a point that it's not sustainable.
Right.
And we're gonna have to look-
Regardless of who the president
Right.
is, regardless of what happens elsewhere, we know that in Texas we're coming to a crisis point.
Absolutely, and we're to that point nationally as well. When
Right.
you've got health care cost at the federal level for the first time exceeding Social Security outlay.
Got it. All right, we have a microphone to the side here. We'll walk around, and we're more than happy to take questions for as long as time permits. Great conversation with our folks. Let's go to this gentleman here first. Yeah, give them a hand. I would ask that you give them a hand. Thank you. Sir.
My question's about pharmaceutical companies and how much influence they have on doctors and the amount of prescriptions and the type of prescriptions that they actually influence you to prescribe.
Let's have Dr. Bornstein wants to jump on the pharmaceutical question. Are pharmaceutical companies the enemy in this conversation?
Enemy, no. Are they part of the challenges that we have? Yes. I will tell you, talk about medications. Dr. Varga and Representative Klick talked about this a little bit. Let's talk about hepatitis C for a minute. Okay, you've probably all seen the advertisements. There's 2 or maybe 3, Dan, I think, new drugs that can cure hepatitis C. Wow, that is huge, because the previous treatments were not that effective and not well tolerated, a whole lot of side effects. So that's great. They're about $100,000 per treatment course. Now, there's about 3 million people in this country that have chronic hepatitis C. So actuarially now, I don't know what % of those people actually are going to move on to have chronic. So you could say, well, if you treat these X people with this drug that's $100,000, but X number of those people don't end up needing a liver transplant, which then the numbers really go up. So those are the kind of things that we really have to deal with. Why does this drug cost $100,000? I will tell you that one of the most remarkable things happened at the last AMA House of Delegates meeting in November. Steve, you were there. When the AMA House, which is a pretty conservative group of people, passed a resolution to ask for, they can't really mandate, banning direct-to-consumer advertising. Wow. By pharmaceutical companies. So there's no question. There's a Senate panel, I know. There's House panel in Washington.
But
really
there's not
looking,
any chance of that actually happening.
Of course
right?
not.
Yeah.
Of course not. But I think it says that physicians don't really appreciate. Ask your doctor if or tell your doctor. That's the one that drives. Tell your doctor if you have XYZ. Well, damn it, sorry. You ought to know if your patient has that. You know, that's relationship-based care. That's a medical home. You're going to know if your patient has whatever. So. Yes, they're part of the issue.
I suspect we could ask the pharmaceutical people whether you were part of the problem, and they would say, I mean, there is kind of like a little bit of this going on, is there not, Dr. Varga?
Yeah, there is. I mean, I still go back to there's a study done some years ago now that said it was actually an exercise, kind of like a Jenga game that says, let's kill all the boogeymen in healthcare. And so they took doctors, pharmaceutical companies, insurance companies, hospital companies, and tort reform. And they basically normalized every one of those things to the lowest level you could find in the Western world, and said, what would the savings be? And I think at the time it was like $500 billion, with this important caveat. Healthcare expenditures at the time were rising about $500 billion a year, which meant in 1 year all the boogeymen were dead and you still had the problem, which healthcare, to your
Right.
point, Evan, was hockey sticking, right? And it ends up coming down at the end of the day to an efficient system of access and utilization.
What you said at the beginning.
Until we get to that, you could fix every one of these things and you're still going to have the exact same issue.
Good. Question in the back or someplace I saw a hand go up, a couple over there. Ma'am, you pick. Okay. Hi.
What kind of I don't know if that's working or not, what kind of preparedness are we doing at the state level for the aging baby boom population and the
Right.
incidence of Alzheimer's and dementia and the cost of care that has the potential to overwhelm
Right.
as well the health
An
care
excellent
system?
question. Representative Klick, I mentioned that in that time frame from now to 2050 when the population of the state will double, whatever other demographic indicators there are, we know that the aging population, the population of seniors will double between now and then. So this is going to become much more of an issue. What are we doing about that?
We actually have already had an interim hearing on the Health and Human Services Committee, and that is one of our interim charges.
On one of those subjects? Right.
So we are looking at that.
Representative Collier, is the state focused enough with all that it has on its plate? Is the state focused enough on the care of current and future seniors?
Well, we need to do more. And you know, the thing is, at the state level, we only know what is provided to us by the experts, which are the people who provide the care. So, you know, I enjoy hearing from Dr. Varga, I enjoy hearing from Dr. Bornstein, because this is education. That's how we get our information. Once you educate us, all of you have that opportunity to provide information to us so that we can make informed decisions that will affect your life and our life. And so the more information we have, the better that we can legislate. So yes, we're hearing, and we do need to take action. But you know, we're at the point now where we're listening and we're trying to find solutions that can help us in the future. But right now, we're just at the point where we're taking information.
Yeah. Good. Another question was over there.
What are your thoughts about all these standalone ER clinics?
What are your thoughts about all these standalone ER? Based on the noise you just made, I'm assuming it's not a good thought. So this was something that emerged from the last legislative session, did it not? The existence of these standalone emergency?
Yeah, I think a lot of consumers initially, when these began to open up, thought that that was going to be a cost savings in you know, getting their care there versus going to a traditional
Not so much?
emergency department. Not so much. And what we have done is ask that they be a little more transparent in their pricing, so that the public, when they go in, is not thinking that it's going to be like an office visit at their primary care
Did I read your guttural noise correctly? You're not a fan of
Well,
these
they're
places?
kind of like pot shops in Denver, right? I mean, it's like every corner there's one now. It seems to me. And so I would say to you, I think it's a great question. And I think that it points to a lot of things. One is the rise of consumerism, whatever you want to call it. And I don't think that's a good description. People want, because of our life, our hectic lives and our connectedness and all that, we don't want to go to a doctor's office and sit there and they're late and for a relatively minor thing. And I get that. And I think that's why I have to circle back to this whole patient-centered medical home thing. One of the things that, one of the most important tenets of good primary care is access. You can't utilize primary care if you can't access it. So one of the things that we are doing with the practices and the doctors we work with is saying 9 to 12 and 1 to 4:30 is not necessarily going to cut it. So you need email access, and people are a little nervous about that, but there's actually good ways to do that. You need phone access. You need people that are connected with that patient to be able to reach out to that patient. So it is, to a certain extent, our responsibility.
How about weekend
Oh.
hours? Since
Since
we're making a laundry list of unrealistic things
absolutely.
we want, how about weekend hours?
That's not unrealistic.
Evan, I wanted to just say, recently I had a good experience with one of those standalone emergency clinics. You know, I was happy that there was one there. Now, I will say that, you know, the emergency clinics probably found out that they can't survive on the cost, you know, on the billing practices that they had, so they had to become emergency rooms, right, so that they can charge higher rates. And so, you know, that's probably how they found out that they could actually make a little bit of money or sustain themselves. But it may be one of those necessary evils that, you know, providing access in the right place. You know, you may not need them on every corner and in the rural area, but It may be in the city area where you want
coordinated, too.
concierge care or some type of form.
Well,
of
and in
it.
fact, Representative Klick, you talked about the free market. Isn't it a case where you let these guys open up and then let the free market sort it out? If they're charging too much, if they're not providing the service we all thought, they won't survive.
That is
Right?
true, and there's a provider now in the Portland, Oregon area that are freestanding ERs, board-certified emergency medicine specialists, CAT scanners, sonogram machines, the works. The private pay fee to go in and access to care is $299. And you have immediate access, not the wait that you typically have
Right.
in a traditional emergency room.
Right.
And
Your
if
CAT
you
scan
require
needed or not.
hospitalization, you're directly admitted to a facility. 90% of those that show up in the ER go home. And we need to look at different business models, and this company has a different business model.
Well, let me ask the business model on the panel. What's wrong with this? You actually are the one up here who runs an emergency room or emergency centers. What's wrong with this?
Well, I mean, it goes back to what I said at the outset. What you're really looking for is an access model that ideally is right care, right place, right time, with the right professional. And when we talk about the free market, the representative was just talking about a group of folks that take a cash payment. It's essentially a concierge ED,
Right.
which is great. That's a free market model. But everybody else's model in freestanding EDs is we've got to find a hospital partner or build a hospital in the marketplace that we can attach our EDs to so we can charge hospital rates for you to come in and get a flu shot or take care of your sniffles. So the risk, and I'm not necessarily condemning freestanding EDs, because in some scenarios they do provide an access model where there's not access and a little bit higher level of capability than an urgent care center, and if you're miles and miles and miles away from a hospital, that may be a good model. But most of the free market sort of approach to that is I want to get a hospital's rate so a patient pays their $50 copay for something that should have been a $5 office copay, and I made $1,500 for unnecessary care being provided. But I will tell you, I think that there is, when you look at insurance plan design that's happening right now, if you're going to invest in a freestanding ED, I'd be really careful, because as somebody's starting to walk around with a $3,000, $5,000 deductible, they're gonna want to know $299 full all in, one price for that for my card, or I'm going to blow through my entire deductible in one ED visit. So as consumers become more and more cost accountable for the care that they get, I think folks are going to start shopping this a lot harder.
Especially with the higher deductible plans now.
Higher
people-
deductible plans,
But
right.
but it's difficult to find out what things cost. We need pricing transparency.
Is there not
too.
sufficient, is part of the problem here, we haven't talked about it, but is part of the problem insufficient transparency?
Absolutely, in a lot of models.
Representative Collier, do you agree with that?
Well, it is, but we did pass a bill that dealt with the plans having to be more transparent this last session, having to be more transparent about what your deductible is, if you go to this place, that place, in network, out of network. There was a bill that said that they have to be more transparent.
What I'm speaking, other types of facilities. I have a constituent that needed an MRI. She had a high deductible plan, $6,000 deductible. She started calling around. Of course, it was very difficult to find out what the cost of those services were going to be, because you had the actual scan itself and then the interpretation. But
The facility
one
fee,
facility,
fee. Forget that one.
one facility quoted her $6,400 for her scan. She went to a freestanding radiology facility in Plano and paid $700.
And got less. Right.
Yep.
Okay, question over there. Ma'am.
We've said on the panel today that chronic care, chronic diseases are increasing.
Yes.
We know at some point efficiency is not going to go any further. You're not going to be. Who are we going to allow to make the decisions of who's going to live and who's going to die if we continue to cut the rates that providers receive for services? There's not going to be anybody to provide the service. You've gotten as efficient as you can. Are we throwing that decision now to managed care companies?
I don't think so. I think it's a great question. It's probably one of the most important questions we have to address. And I think we need to depoliticize it as much as we possibly can, because it's not about death panels, it's not about care rationing. It's first and foremost, as both of our representatives have said, about education. folks need to be educated about the realities of chronic illness, the outcomes of chronic illness, how we improve quality of life through those chronic illnesses, et cetera. But the dilemma we face is this. If you look at healthcare, say in the 1960s, 1970s, and look across an individual's lifetime, what you would see is that there was a little bit of spending at birth. If you're a woman, a little bit of spending around the time that you were raising children, not much spending at all, and then we spent a whole bucket full of money, and then you died. What we've done in the meantime is we've spent a whole lot more at birth because we've got a lot of, our ability to take care of prematurity and everything else is exceptional. We spent a lot more during women's childbearing years because that year got pushed back, and now we've got lots of other ways that women get pregnant, deliver babies, they're higher risk pregnancies. Then we discovered all this prevention stuff that we mandated you start to cover, and it's a good thing. So we've prevented diseases, and we spent a lot more on people between childbearing years and senility. But what we didn't change was we pushed death way out. We put Medicare life expectancy, when Medicare was passed in the mid-60s, the age, so we set the age at 65. What was life expectancy then? 64. So life expectancy for the average male was younger than the day that
life expectancy today is
80-something, depending upon the demographic you live in. But on average, it's 80. So we've pushed it out 15 years with a lot more expenditure, and we still spend most of your health care dollars in the last 2 years of life. And the answer is that's not a medical technology issue. No. That's not a, it's not a get more doctors issue. It is a public education issue. It's a cultural discussion. And it's been so politicized that we're really struggling to have the conversation. And again, I would argue it is a cultural conversation. And I will say the role for government does a great job of helping to educate people in the public health world. I really believe that. Just remember what happened with cigarette smoking in the middle 50s. Had breakfast with George Will yesterday morning, and he was saying, when I arrived at Trinity College in Connecticut in 1958 to begin college, somebody knocked on the door and walked in and handed me a free pack of cigarettes from the tobacco. And just look at where we are today with respect to that. And that was by and large a combination of thoughtful public policy and massive education that was done over a long period of time. We need to do the same thing around end-of-life care.
Representative, you want to get in that?
Yes, I want to just, I think you have a valid point. What you asked about whether the managed care organizations. The managed care organizations are given a set amount of money to approve certain types of medical treatment. But they also want to make money. So what they need to do is find that medium of where they're dishing out the dollars that they're responsible for to pay for the care, but then also reserve some for themselves to be able to pay their bills. And so you do see that dilemma. There's a hint of that dilemma in there when you're saying, look, are the managed care organizations making the decisions? They're not medical providers. They're just people that are sitting there looking at a computer, whether they're approving the physician's fee or not, the charge or not, or the actual type of treatment. So, there is a level of concern that we should have as to whether these managed care organizations are making decisions about our healthcare treatment that may be against what our doctors or our dentists or whatever have decided for us for our care. So we do have that level of concern. I think we do need to be mindful of it when we're giving a lot of control to these managed care organizations.
Agnes is telling me that unfortunately our time is up. We could have more questions and more conversation. Really great discussion. I want to thank and acknowledge our great panelists, Sue Bornstein, Nicole Collier, Stephanie Klick, and Daniel Varga. Thank you all for coming, and thanks again to UNT for having us. And hopefully we'll see you again. Thanks very much.